Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the March 2019 edition of PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Kyle Sanniec from UT Southwestern. Today, we have the honor of being joined by Dr. Summer Hanson, Assistant Professor and Director of Translational Research within the Department of Plastic Surgery at MD Anderson Cancer Center. Thank you so much for joining us, Dr. Hanson, for this PRS Journal Club podcast.
Thank you for having me.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing today is Barriers of Access to Breast Reconstruction, a systematic review by senior author Dr. Tony Zong and colleagues in Toronto, Ontario, Canada. The purpose of the systematic review was to comprehensively summarize barriers of access to breast reconstruction and to evaluate access using the Pachansky and Thomas conceptual framework, which is based on 6 dimensions of access to care that includes availability, accessibility, accommodation, affordability, acceptability, and awareness. So the authors performed a systematic review that focused on 3 similar and related topics of breast reconstruction, barriers, and breast cancer. They searched 8 databases and reviewed the English literature to come up with the Pachansky and Thomas conceptual framework based on those dimensions of access to care. They included a total of 99 articles that met criteria, and all of these studies were observational and qualitative, as randomized controlled trials in this subject are rare. The availability of breast reconstruction was determined to be highest in teaching hospitals, private hospitals, and national cancer institutions. Accessibility affected access with a lower likelihood of breast reconstruction in geographic locations that were rural compared to urban demographic and geographic locations. Affordability also impacted access in the way that high costs of the procedure or poor reimbursement by insurance companies negatively influenced access to breast reconstruction. The acceptability of the procedure was not universal, which was interesting, with unfavorable physician attitudes towards breast reconstruction and specific patient and tumor characteristics correlating with lower rates of breast reconstruction. Those physician attitudes in the studies that were included were mostly from the ablative or oncological surgeon. Lastly, a lack of patient awareness of breast reconstruction reduced the receipt of breast reconstruction. And as this is a systematic review, this reinforces several recent papers that have shown a lack of knowledge even about breast reconstruction, and then furthermore about the options within breast reconstruction. The authors conclude that using the Access of Care framework by Pachansky and Thomas, that there are several barriers to breast reconstruction exist, and they exist in all 6 of the domains, and these interplay at many different levels. The systematic review also analyzed a complex relationship and suggested a few interventions aimed at targeting breast reconstruction barriers in the goal of promoting equitable access to breast reconstruction for all breast cancer patients, which is an incredibly important goal going forward. So with that, I wanted to get your thoughts, Dr. Hanson, just to start out on what you thought about this article, and then what are some solutions to improving breast reconstruction disparities and access to care that you've successfully been able to implement?
There were a couple of takeaways from this systematic review, and I'd start by saying that with almost 100 papers that were included, there is a lot of research out on disparities in breast reconstructions with so many factors that interact. When I first read this, I was actually amazed that we do any breast reconstruction, and yet here I am always busy. So I think the authors do a great review and summary of the disparities that we see in breast reconstruction, and I liked the organization on this conceptual framework put forth by Pachansky and Thomas. I think probably the most straightforward first step is an educational piece, potentially affecting both awareness and acceptability. The Breast Cancer Patient Education Act of 2015 was a good push for public awareness, by our society, ASPS, and other organizations, and really prioritizes breast reconstruction in patient education and public service campaigns. I was really surprised to see that physician perception of reconstruction and the impact that it had on, the acceptability of referring physicians. The idea that reconstruction can interfere with adjuvant therapy or surveillance is shocking to me still at this day and age. That was something that my grandmother was told back in the 70s. And so the thought that those misconceptions are still keeping women from even having a discussion about reconstruction, I think is something that we definitely need to change. I think that, being at an academic center, we have an obligation in teaching and in education. And so that's not only on a trainee level and training the next level of reconstructive surgeons, but also patients. And now I'm going to add our referring physicians into that mix. One thing that we've done here is really taken on that piece and worked with specialists in patient education and health economics and decision scientists, and put together modules that we can deliver to patients either electronically or while they're in the waiting area, and giving them information, even in an online module as well, just about options for reconstruction, when to have that discussion, what they need to consider, how it all sort of fits into their cancer care, and then things that they should think about as they're going through this process, and how their personal goals, their social goals, their physical well-being, how that all can affect their reconstruction, and how their reconstruction or their choice in reconstruction can go back and affect that. And so that's something that I think is pretty straightforward to do and less challenging than trying to get into affordability, availability, those sorts of things. When we start looking at some of these other domains like accessibility and accommodation, I think those are much harder to try and implement change on the individual or institutional level. Reconstruction is always going to be more accessible at a larger academic center or an urban hospital, and there are many factors that go into that. Even on a training level, from a plastic surgeon standpoint, I grew up in a small town, and I have family that still lives in a very small rural area, but I like living in a big city. I like being at a big academic center, and I think that to do some of the complex reconstructions that we do in multiple flaps and reconstruction with lymph nodes and things like that, you want the additional resources that larger hospitals can accommodate. So trying to train plastic surgeons to go out into a rural community, I don't know that that's going to be where the benefit will come from, but I think at least trying to work on the educational piece and making it more aware and acceptable for people to talk about it and to alleviate some of these misconceptions, I think is probably the biggest hurdle to start.
Yes, definitely. I completely agree. I think there's some things that we are able to directly influence, and then there's some things that are so large from a systems-based standpoint that we really have as a group and the societies, we've somewhat been able to leverage with the Women's Health and Cancer Rights Act, making coverage for these operations or right to all patients, and obviously with the Breast Reconstruction Education Act that you mentioned. I think one of the things that you touched on is the geographic disparities, and something that really came out in this article, and there's been recent articles written. There was a PRS article in 2016 talking that it's as you increase travel distance to a reconstructive surgeon, there's a linear decrease in the rate of reconstruction or receipt of reconstruction. And I certainly think that all of us are at major academic hospitals, but we're surrounded by several rural communities. And we see this from patients, at least at our center, and I'm sure everyone does as well. It's very difficult for patients to travel greater than an hour or 2 hours, especially if they have two-staged reconstruction and come back for their expander fills. And I think that kind of bears itself out in the literature. But as you mentioned, it's very difficult to train plastic surgeons and then say you have to go to a rural community where you may not have the same opportunities from a broad reconstructive practice standpoint, or even if the hospital doesn't have the resources, if they're not equipped with microsurgical capabilities, or you're a single surgeon practice, and monitoring your flaps from a hospital standpoint is very challenging. So what are your thoughts on centers for excellence? I think all of us are in NCI cancer centers and centers for excellence, and having patients being filtered to these centers versus continuing to try and provide plastic surgeons for the rural communities. And I guess one of the concerns I have with having plastic surgeons in rural communities who can't do microsurgical or autologous breast reconstruction is that eventually will you see a bias in the type of reconstruction patients have, and then an increase in, I don't want to say the wrong type of reconstruction, but potentially an increase in prosthetic reconstruction patients who are clearly poor candidates for that.
So I think you touched on a couple of things. That's definitely a possibility. Going into these rural communities, and even if you have the technical skill set to do a deep flap, to convince your small town hospital that you need a microscope and you need SPY. I mean, at a minimum you need a microscope. Maybe you don't need SPY, but you need to routinely get CTAs on patients who have had surgery, and then you're going to be the person who's there and constantly on, and if there's a take back, you're on your own, and you've got clinic the next day or you've got cases the next day. And I think there are a lot of challenges to try to overcome. I think that being said, having more plastic surgeons that are at least trained in those techniques or are familiar with those techniques, potentially, again, that educational piece, like referring on to larger centers if that's suitable, One of the things we do here is, we each also go out to one of the community hospitals to see patients, but then we bring them to the main campus for their reconstruction if they're in need of, a complex reconstruction or a free flap. And while it's obviously still burdensome to the patient, at least they're having that conversation ahead of time and they're knowing what their options are rather than coming in with a complication or a problem with an implant after radiation or something like that. I think that's one thing that we're trying to improve on as well.
Yeah, I think those are excellent points. I think as hospital systems become larger and they're purchasing more of these smaller hospitals in the surrounding areas, that's something we've definitely seen in St. Louis with our hospital system purchasing some of the other hospitals in Missouri and Southern Illinois and kind of in a couple of states around us, that there's an increased incentive to send, as you mentioned, plastic surgeons and just surgical specialists to have an outreach clinic, so to speak, one day a week or a couple days a week, and then for places that don't have the capabilities of having the more complex operations or the infrastructure to have those operations done at the main campus. And I think that's something that's worked pretty well for us, and something that Dr. Zong mentions in this article is to just have the availability to do that. And then I think that kind of ties into the concept that you talked about, which is education, which I agree is completely critical. There's a disconnect between patients who only see their oncological surgeon and then patients who are actually referred to a plastic surgeon. And obviously their receipt of breast reconstruction, there was an article that they cited that said that there's 100% lack of reconstruction in patients who are never evaluated or referred to a plastic surgeon. So I think the patient's self-education and self-awareness of breast reconstruction is still lacking compared to if they're able to see a reconstructive surgeon, obviously. Kyle and Lily, I wanted to get your thoughts on some of the solutions at your institutions or what you guys have tried to do to improve access for breast reconstruction, specifically in the communities surrounding your primary city.
Thank you, Raj. So we have started to work, sort of expand our reach out into some of the areas, sort of in many ways similar to what you guys are doing in St. Louis and what Dr. Hanson mentioned, having our providers have clinics in areas that we previously weren't in, and then bringing back our more complex microsurgical reconstructions back to our main academic center. Another thing I think we see a lot of, at least here at Duke, is we're one of only a handful of centers in our state that provides microsurgical breast reconstruction, and so we have a lot of referrals of patients who've had complications from implant-based reconstruction who come to our institution to manage their complications, which is probably the same at all of your institutions. And I think it just is reflective that even, the problem is probably much larger than even this study is capturing, because it would consider anyone who had an implant-based reconstruction to have received breast reconstruction, even if maybe that wasn't the best option for that patient, and that patient just never had access to a microsurgeon. So I think these issues are almost even larger than this captures.
I think that's a great point, Lily. Kyle here. It's been very interesting being at UT for training, because we have access to UT Southwestern, a big academic center. We have access to Parkland. We go out into the community. So I get to see a bunch of different approaches to this. At UT, it's great. It's really multidisciplinary approaches. Breast surgeons, plastic surgeons, oncologists, everyone's involved basically from the get-go. There's no do I need to refer to plastic surgery? Just when a patient comes in with cancer, that's the whole process. Everyone just knows that's how it works. When I first started at Parkland, it was difficult to get some of the breast surgeons on board, and they still kind of had a thought that, this is a cancer, let's do just a mastectomy, and then if you want reconstruction, do it later after all your cancer treatment is done and things like that. And it was hard getting, our coordinator to schedule stuff with their coordinator. One of our coordinators left, and we ended up just uniting, so the breast cancer coordinator and the plastic surgery coordinator at Parkland was the same person. So they had access to all the schedules, so they could sort of pick and choose, make sure that the flap team was available on the day that this patient was getting a breast reconstruction and getting their mastectomies if they wanted to do immediates, or tissue expander team was available and things like that. But looking out in the community, there's a lot of physicians who maybe didn't have as much free flap training, or when they did, it was just kind of starting out and they had complications, and they get great results just with implant-based reconstruction, or just with one type, and that's what they're comfortable with, and that's unfortunately what the patient gets, and they may or may not get all of the options. And then lastly, what I've seen at some of the community institutions is there's this big economic push to keep everything in the system itself. So they don't want to refer to a big tertiary center, because then that income that is generated from that patient in terms of labs and other testing and all the ancillary income, not just the surgical income, ends up getting lost to the other institution. And so they're worried about it. And I think that also plays probably a bigger role than we all realize in terms of the economics that's driving reconstruction.
I think that's an excellent point, Kyle, and I think it's something that the authors and Dr. Zong touched on is the affordability. But I think, like you mentioned, the economics of it really stresses in many different ways, and it presents itself in many different ways. It's not just that patients with private health insurance are more likely to have breast reconstruction and patients in lower socioeconomic groups are less likely. I think there's also insurance reimbursements and how that influences the acceptability, so to speak, of surgeons in the hospital systems of doing breast reconstruction. I think one of the barriers that we see is not only in getting access to breast reconstruction, but then in getting access to the full spectrum of breast reconstruction and having all of your options discussed with you, as breast reconstruction still remains a preference-sensitive decision. You really do want patients who are referred to a reconstructive surgeon to also have all of their options discussed with them. Dr. Hanson, I wanted to get your thoughts on how insurance and potential changes in insurance reimbursement can impact breast reconstruction and access to breast reconstruction, and also the specific types of reconstruction. There's a push, at least in some surgical specialties, orthopedics primarily at this point, but also coming in cardiac, for bundled payments and having kind of just a lump sum payment for receiving care. And there's some thought that that might be coming to cancer care, although probably potentially further down the road. How do you think if we had a bundled payment that would affect breast reconstruction? Would it potentially improve access or actually negatively impact patients?
That's a good question. That's tough to predict how things are going to change in the future as far as insurance and reimbursement is concerned, but I do think it would actually harm patient outcomes, or at least negatively affect patient outcomes. One of the more recent surveys from ASPS looked at random member survey, and I think something like 6% of the respondents actually offered microsurgical reconstruction. So I think if you're going to change the payment structure, the reimbursement structure, you may see surgeons or other hospital administrators affect how we can do our reconstruction or what kind of resources we have available. You know, that's one of the things that for people who do more implant-based reconstruction, you know, always the argument of whether or not to use the acellular dermal matrix or to do things sub-pec or pre-pec or things like that. Decisions that we might now consider on a patient level that may definitely have an effect, the reimbursement piece. Something else that strikes me when patients come in is the indirect costs that I don't necessarily think of, like them coming back to the medical center and having to pay for parking every time they come in, or having to take an afternoon off from work, or have someone watch their kids if they're a stay-at-home mom. And all of these things that go into it that definitely weigh on an individual level, that you think, you know, this is your reconstruction, in 6 months from now you won't even think about it, it's not a big deal, but it certainly has an effect on their day-to-day and their decision-making.
We have really started to look into that here at Duke, sort of thinking about the financial toxicity of not only the breast cancer, the cancer treatment, but also the reconstruction and the reconstructive treatment, and sort of where we're doing well for these patients and where we're doing them a disservice. And I think hopefully we'll have some more information and some more details will, you know, sort of evolve in the coming years about how patients are truly impacted by the number of surgeries they undergo for, you know, reconstruction and what that really means for them.
Just like we've improved how we counsel patients by the addition of the breast queue, I think this is kind of the next level of reported outcomes and shared decision making and patient counseling, is what impact it has on, you know, as you said, financial toxicity or indirect outcomes and things like that. I think that it's just helping us build a more complete package when we talk to patients about reconstruction.
Something that we had brought up before was the awareness of the breast cancer surgeon, and I think this was something that also really surprised me when I was reading the article and just getting a sense of the overall negative view some of these surgeons had on breast reconstruction for surveillance reasons or what have you. What do you think our responsibility as plastic surgeons is to change this thought process? It seems like we must not be doing something for them to continue to think this way. Is it publishing enough in their literature, or what type of educational outreach, or is it just something that takes time with different breast surgeons seeing successful breast reconstruction? But I was just curious as to your thoughts on what our next steps should be as a specialty to try to provide some better education to the other surgeons, not just the patients.
Well, I think one of the things that is helpful is, just like we have multidisciplinary clinics and multidisciplinary team approach, is to have multidisciplinary conferences that people would attend, having radiation oncology, medical oncology, breast surgical oncology, plastic surgery, and I think just being a part of those kind of educational conferences and discussions and things like that. I think publishing, you know, expanding beyond PRS, even though PRS is by far the best plastic surgery journal, you know, I think adding to that, or PRS has the summary of, you know, plastic surgery relevant articles that are in other journals or other publications. I think trying to bring more awareness to, say, Journal of Surgical Oncology or JACS or something like that, and try to get more of our publications like this systematic review in those types of journals, I think is something interesting as well.
Yeah, I think that's a great point, Dr. Hanson. I think it's something that we've tried to look at here in just across surgical specialties, looking when you publish disparities research to try and publish it in the journal that is most read by the group you're trying to target. So for breast reconstruction, that would be, at least if you're trying to improve awareness for the oncological surgeons and intergeneral surgeons, would be in their literature, because I think that obviously the PRS journal for us is the best journal, but for sometimes improving outreach, it is expanding beyond our own journal and getting it into their journals. So I think that's something we can definitely hope to do in the future. I think with that, we will end the discussion of this article. Thank you everyone for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes store. Also remember to tune in to the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for a monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Hanson, for joining us today.
Thank you.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.